Buenos días, gracias a todos los patrocinadores, en especial a Affinity, por permitir hacernos cada semana las clinical lectures, con las cuales yo aprendo un montón y espero que hoy puedan aprender también. Haré la charla en inglés, fue un reto que nos fue pedido y bueno, lo acepté. So let's start. I'm going to talk about moderate heat burns. And what is it? It's a burn injury to the skin that happens for, the cause is a long period of time that the skin is exposed to a moderate heat. We're talking about more or less 40 degrees. The most common cause are heating pads. And this is the motive why I'm talking about this today. This is not that rare. We see it quite often, and it's really important to know how to recognize these injuries, because unfortunately, the most of the times we do it. We cause it. It happens in our clinics, in our hospitalizations. Actually, in the States, is one of the most important causes of complaint of owners, and it can bring us legal issues. So, and it's a very specific presentation of burns, of burn injury. So let's talk, in 2006, this paper of, made in America, the authors referred already that the most of the cases of burns were caused accidentally in the clinic. So it doesn't happen just here. I'm going to talk about burns in general, to explain etiology, pathophysiology, and then the clinical presentation. I'm going to focus on these specific presentations. Usually I'll bring two cases just to represent two different presentations of moderate heat burns. Then we'll talk about generally, burns in general, about therapy and prognosis. And I based this presentation on a paper of 2016 of veterinary medicine and the guidelines of human medicine of wound management of burns of 2016. Etiology. There are many causes of burns. The most common are thermal burns, but it can also happen with chemicals, electricity. Usually, in veterinary medicine, in small animal practice, we see most often burn injury to the skin, but other organs can be affected, especially if it is a burn caused by fire. Smoke inhalation can bring really serious complications, and those cases must be referred to a burn unit. But today I'm just focusing on thermal burns and the ones that cause, and I'm just focusing on dermatological lesions. So we can burn the skin with high temperatures. It doesn't take long. It's pretty quick, above 70 degrees or so. Fire, hot metal, boiling liquids, hair dryers, a common cause. It's quick to burn. And moderate heat burns that happen with moderate temperatures, these ones must be in contact with the skin for more or less 1 to 6 hours to start causing injury. And so today we are going to talk about these two specific presentations. One, the cause, the heat source is heating pads or any other device that we use to prevent hypothermia. And the other one is acute sun exposure. So the source of heat is the sun. In general, pathophysiology of burns can be explained by the Jackson's model. That explains that whenever a burn happens, we have a coagulation zone, which is the zone of maximum damage to the skin, and the skin suffers necrosis. Then we have a stasis zone around it. It's a zone of hypoxia, vasoconstriction. Actually, it's the zone that if we don't do nothing, or if the if the hypoxia goes on, it becomes a coagulation zone. So this is the focus of our treatment in the first days or hours. And then we have a more peripheral hyperemia zone where all the acute inflammation happens. So we have vasodilation, erythema, pain, edema. Seeing this applied in a practical example, this is a dog from here. It's very obvious that it has a big lesion here, but I really want to focus on this one because it really suits on the Jackson's model. Okay, so as we can see, we have here this point that we can see already some necrosis going on. We can imagine that this is going to progress to a scar. And then we have this zone around that is pretty white, pale. And then we have a peripheral zone of erythema. Okay, so this would be more or less what Jackson's model explains. Burns can be classified by depth of lesion. Previously or historically, we used the terms of degrees, first degree, second degree. Nowadays, we prefer terms like superficial burn or partial thickness. So in veterinary medicine, we usually divide in these 4 types: superficial burns that affect the epidermis, partial thickness that can be superficial partial thickness, or deep partial thickness if affects superficial dermis or deep dermis, and then we have the full thickness burn. In the superficial burn, what happens is that first we just have lesions on the epidermis. So basically the cells that are affected are keratinocytes that suffer necrosis, they die, and they stimulate the upper dermis to develop inflammation. So usually we have erythema, we may have edema, but the lesion is dry. It's just the epidermis that is affected, and it can be painful. How do we distinguish erythema from hemorrhage? Erythema blanches. For the ones that don't recall or don't remember what is it to blanch or not, it's is a term that we use to describe a method which is called dioscopy. And basically when we have erythema, which is vasodilation, the blood is within the blood vessel, if we make pressure with a glass slide, we compress the vessel and the erythema goes away. So if it blanches, it's because it's erythema, not hemorrhage. So as you can see here, red, we pressure and it becomes white. In superficial partial thickness, we have epidermis and superficial dermis affected. In the superficial dermis, the vasculature affected is really microcirculation, and usually within the first 24 to 48 hours, microcirculation is recovered. The lesion clinically is moisty. We see erythema, but it still blanches because it's really a superficial injury to microcirculation. And it can be painful. This is a case that we see just 2 days ago. And here, in this area, when we did dioscopy, pretty much everything went away and blanched, and a few spots were red. So part of this lesion was superficial partial, and part of it wasn't. And it was this, deep partial thickness. So this one, deep partial thickness, affects the epidermis, the superficial dermis, and the deep dermis. The vasculature is more profoundly affected. The nerve endings are also. Sometimes nociceptors are affected, and this may reflect that sometimes we have pain, and other times we have hyposthesia. The lesion usually, because the blood supply is already really affected, we have, it's a pale lesion, as we can see here in the center, or it is red, but it does not blanch, meaning it is hemorrhage already. As we can see here, if we put the slide, it will go away, erythema, but not here. This is not erythema anymore. This is hemorrhage. Then we have the full thickness burns, which affect epidermis, dermis, panniculus. It can go further to bones, tendons, muscles. This is a picture of a full thickness burn with 7 days, more or less, and we can see that it's bloodless. It is a necrotic lesion, a vascular. Usually the skin is white. It seems like leather. It can be grayish or black. It may become extremely dry and thick. Usually it's not painful unless you pressure deep. And of course the skin is dead, so hair here is plucked very easily. This is another example. This was not a moderate heat burn, this was a burn caused by fire, but this is just to show you how deep the injury can go. It is important to know that in this kind of burns, more or less, initially the microbiota, the gram-positive bacteria initially start to colonize the wound, but as the time goes by and more or less by the 3rd or 5th day, other bacteria can provoke infection, and Pseudomonas is one of the frequent ones. So we must be aware that this can get really infected. In this paper that I mentioned of 2017 of veterinary medicine, there is this nice table that summarizes all the key features of each of these burns that I've just talked. So clinically, as I said, burns, the most frequent ones, thermal burns. I'm not going to talk about frostbite or high temperature burns. I'm just going to talk about moderate heat burns, and I'm going to talk specifically of these two kinds of presentations. And let's start with heating pad burns. As I said, they are pretty much unpredictable because no one expects to burn a dog with a pad at 44 degrees, but it happens because the skin stays in contact with this heating pad for long periods of time. There are some facts that may enhance chances for this to happen. For instance, if the dog has short hair or if the hair was clipped, as in this case, if it is wet, either the dog or the towels that we put around, or if the dog had subcutaneous fluids. I'm always talking about dogs, but obviously this can also happen to cats. And I'm bringing you this case, Duna. We saw her this summer. She's a Yorkshire, 8 years, female, and she was presented with the history that 3 days before she had been bitten in the park by another dog. She had a cervical luxation at the level of C2, C3. Everything of general blood work was normal. Abdominal ultrasound, X-rays, all normal. On her primary veterinarian, she did amoxicillin, carprofen, and then she came to our hospital and she was treated with clindamycin and enrofloxacin, and this was just for the 2 last days. So we see her on the 3rd day, and we see that she has this erythematous, and a little bit of necrosis already here. In the picture maybe we don't see, but it is she had most of these point and pale lesions were plaques, were edematous. And our diagnostic approach was, first we did a cytology, which was unremarkable. Dioscopy was positive or negative, as I explained to you, depending on the zone, and she had moderate pain. Our differentials were thermal burn, based basically on history and clinical presentation. We also thought about adverse drug reaction or contact dermatitis. To distinguish between each other, we should have performed a biopsy, but because Duna was here at the hospital, we were seeing her every day. We decided to monitorize her day by day, and meanwhile we decided to apply a little bit of topical glucocorticoid to diminish the inflammation, and silver sulfadiazine on the ulcers. She progressed as a burn would progress. So by day 9, she had all the first degree or the superficial burn, and the erythematous area went away, and she just presented this central E-scar. And then by 1 month later, all the wound healing went like burns usually do, by retraction and reepithelialization, and this is how she progressed. It is pretty obvious here, the retraction and the scarring. You can see her evolution, and this is important to see that. Do you see that? Here, all the parts that are the hyperemia zone and stasis zone really progressed rapidly, and then after 1 week or more, just the central E-scar was present, and this took 20 days to this. So it takes time, and she was perfectly fine otherwise. She was healthy, but this recovering from these injuries takes time. Key features, history, think about them when you see a dog with this kind of presentation and he was hospitalized or under anesthesia. Wound healing, remember that it takes time. Usually it heals by itself, but it takes time, and it has a good prognosis. Okay, the other presentation is dorsal terminal necrosis. This is a very well described clinical presentation. In this case, it's not a heating pad that causes the burn, it's the sun. It's the intense solar exposure for a few hours. Usually it happens in dogs with black skin or black hair that absorbs the sunlight much more intensively than white skin. And it's more often seen in dogs that have reduced mobility. In 1999, there was this first report of a Dalmatian puppy that in his black spots, and he was exposed to the sun, he developed this full thickness necrosis. Then in 2011, a case series of dogs that supposedly were suffering from burns, and the theory in this case series was that the dogs were exposed to the sun, the owner would come home, would see the dog with a heating stroke, and would take the hose of the garden to water the plants, and would bathe him. And they hypothesized that here the water was the source of heat, but now, after so many cases reported, maybe these cases were dorsal terminal necrosis, and the watering of the dog was not the cause itself. We'll never know. In 2015, there was a case report in a pig, and now just this year there is this case series of 16 cases, which describes pretty well this clinical presentation. And this is another example, also this summer here. A Labrador, 14 years, he had pretty severe arthrosis, and the mobility was severely affected. He was chronically medicated with chondroprotectors, and the history was that this dog This was September, and this dog 3 weeks earlier went to a pet hotel. The first week he was not moving much. They medicated him with meloxicam and gabapentin, but he developed some GI signs, so they stopped the medication, and by the second week, skin lesions were detected. The dog was checked out, came home, and in between this period and the visit, 10 days went through, and in the first 4 days, they applied topical gentamicin, and primary vet did injectable glucocorticoids. Didn't get better, and the 2 previous days to the consult, he was doing topical chlorhexidine and enrofloxacin. This is how he presented. As you can see, he had lesions, dorsal lesions here. Remember that he spends most of his time of day laying down. So this is, in Ron, this was the part exposed to the sun. He had lesions also in the elbows and pressure points. And the lesions were these nasty scars with purulent discharge underneath. On the other side, the same thing. So underneath this scar is a necrotic tissue and a suppurative lesion. Our differentials were again thermonecrosis, thermoburn, and drug reaction. He was medicated with a few drugs that could cause it. In this case, we decided to biopsy, and meanwhile, we decided to do an scar debridement. We kept enrofloxacin because, if you remember, he was just 2 days on enrofloxacin and he had already the lesion. So if it was a drug reaction, it was not to enrofloxacin, and we started silver sulfadiazine. This is just to show how the scar is. So the scar is necrotic tissue, and it should be removed. And underneath, usually this is this bed of granulation tissue. This was his biopsy, as you can see here. So here is epidermis, and here starts the necrosis that affects the epidermis and the superficial dermis, and then we can see also inflammation in deep dermis and affecting the panniculus. In this picture, it is pretty obvious that epidermis is really severely affected. Epidermis, if you recall, has the stratum corneum, and then it has the living epidermis, where keratinocytes in this picture are severely affected. They are pale. We cannot distinguish very well the limits of the cell. And then there is epidermal-dermal separation, and also the collagen fibers are pale, and this reflects the lesion histologically. In this one, you can see you see that the stratum corneum is like fading away the color, and you cannot distinguish here anymore any keratinocyte. All these cells are dead. Also, the collagen is affected, and it's not just the superficial epidermis that is affected, as it goes into the pannicule, the hair follicle here. Watching this more closely, see how the hair follicle epithelial cells are not seen anymore, and the old hair follicle is fading away. So Ron went to his primary vet that was very kind and sent us some pictures, and he progressed as a normal burn would progress. This was by 1 week later, and I don't have pictures, but we spoke with the primary vet, and more or less everything was resolved more or less in the 6th week. So dorsal thermonecrosis, key features, and what do we know from this paper? Most of this, it was 16 cases, most of them happened between May and September. Most of them were in dogs with dark hair. Some of those had just brown hair. And these dogs went to a long hike on the mountain or a long walk or running. Just 5 of them were left outside unattended. In average, all dogs were exposed more or less 1 to 6 hours. We are not talking about unusual temperatures. We're talking about more or less 24 to 43 degrees and an average of 33. It happens here in Catalonia all the time in summer. Just 4 of the 16 dogs had a heat stroke a few days earlier. And the owners detected the lesions between 2 to 10 days and a median of 3 days. So more or less by the 3rd day, we start to see owners start to see the lesions. Almost all dogs presented a really really extended lesions affecting almost all dorsum. The lesions are very typical. They have this serpiginous, linear aspect. Most of them presented erythema, ulceration. E-scars were seen in half of them, and more or less half of them had secondary infections. And now again to the general picture. How do we approach this kind of injuries? 3 things are important here. Timing, because we don't treat this wound the same way in the first few days as we do it 1 or 2 weeks later. Depth of the burn and extension. So the first thing to do is hydrotherapy. Whenever we see a patient in the first days with erythema mostly, and we suspect of this, we should do hydrotherapy. Don't use cold water or ice, because instinctively we tend to do that, because we provoke vasoconstriction, and this would make hypoxia more intense, and we don't want that. So use water more or less at 12 degrees for 15 to 30 minutes. Do not immerse the dog or the cat, because you want to cool down the wound, not the entire animal. Topical corticosteroids, use it or not? Well, what we know is from human medicine, there are no studies that clearly show you that with or without glucocorticoids you have better results, but in this guidelines of 2016 it is the expert opinion that corticosteroids should be used topically in the first 24 hours to reduce edema, vasodilation, erythema, etc. Because reducing the inflammation in the beginning, it reduces the pain and can enhance wound healing. There is this paper then that they tested rats with and without glucocorticoids and with burns, and they saw that with prednisolone in the first 24 hours, the hypoxia area, the non-perfused area, was reduced, and this reflected in accelerated angiogenesis and quicker wound healing. So topical corticosteroids, yes, but for the 2 first days, and don't use it from the 3rd or the 4th day, because by this time, this is demonstrated. By the 4th day, it delays wound healing. What about antibiotics? We know that antibiotics systemically shouldn't be used unless you have an animal that is really prone to develop sepsis. You shouldn't have to use a systemic antibiotic. You can use topical, and the one that has better results either in human medicine or veterinary medicine is silver sulfadiazine. It is broad spectrum, it has no important side effects, and the only thing is that it may delay a little bit the separation of the E-scar to the necrotic tissue. You can also use others like bacitracin, polymyxin, neomycin. The honey-based products, which are very popular, until now there are no studies that show you better results with honey-based products compared to silver sulfadizine. What about debridement of the eschar, of the necrotic tissue? This will depend on timing. It is not clear that exactly by day 3 the area of injury is delimited, but more or less we can predict that by the 3rd day the area will not extend further, and more or less between 1 week or 10 days the necrosis will stop. So when necrosis stops, you can start to clean surgically the area and perform an eschar debridement. Why? Because the eschar is a bed of to bacterial overgrowth. So by removing it, you diminish the risk of infection and you accelerate wound healing. Prognosis. Superficial and superficial partial, the ones that affect just the epidermis and superficial dermis, have really good prognosis. They may be as fast as 1 week or as long as 3 weeks to heal. Usually they heal with minimal or no scarring. And the wound healing is done by contraction and reepithelialization. So and it happens because although the burn affects the epidermis, a few germinal cells are still available to promote reepithelialization. In deep partial and full thickness, and we are talking about dogs and cats that have a total body surface area under 20%, the others are at a risk of developing sepsis, and that one are the ones that should be referred. But the ones that have less than 20% of their bodies affected, the wound healing happens by contraction and reepithelialization. Depending on depth, it can take weeks or months. Usually leaves scars and alopecia, and it may need skin grafts or skin flaps. And to end up with, the take-home message is: include in your differentials, whenever you see a dog or a cat that recently had been under anesthesia or hospitalized, and if in the first 3 days you see erythema, edema, pain in the contact areas, when you know that heating pads could be touching the skin, think of these clinical presentations. Think that if you treat early, you can prevent sepsis and diminish scarring. It is also very important to communicate this to the owner appropriately. If you see 1 week later, and these are the most common cases, you see 1 week later already with eschars. And when you see at that point, all you can do is prevent further necrosis, perform debridement of the eschars. And you will see that these patients, the lesions look bad and it's necrotic and you have eschars, but otherwise the patient is healthy and the skin is healthy. So treat lesions based on timing. Usually these lesions have a good prognosis. It takes time to heal. Prevent the owners about it. And well, the best treatment is prevention, and I hope that everyone can prevent this from happening more often. And that's it. Thank you.